Good morning and welcome to our first sepsis webcast of the 2020 calendar year of the Ohio Hospital Association's statewide sepsis initiative. I'm James Giuliano and I serve as Vice President of Quality Programs here at the Ohio Hospital Association. It's my pleasure to welcome you. We know that sepsis patients are sometimes transferred from one facility to another. We know that such a transfer from one hospital to another involves a sending hospital, a transporter, and a receiving hospital, all of whom are critical in the timely care of the sepsis patient. Today's program will provide us with the very unique perspective of the sending hospital. Joining us on our call today are members of the OHA-HIN, the OHA Statewide Sepsis Initiative, the Ohio Department of Health, the New Jersey Hospital Association, the Hospital and Health System Association of Pennsylvania, and Sepsis Alliance. So we welcome all of our guests as well. Please know that you will be given an opportunity to type in questions throughout the program using our chat box feature. Questions will be addressed at the end of the presentation. We do encourage you to submit questions as they come up, and again, just type them in through the chat box feature or the question and answer box. We will then address them at the end. This presentation is being recorded and will be posted on our sepsis webpage, which can be visited at ohiohospitals.org/sepsis and by clicking on the education link. There you will find all of our previously recorded sessions that do not contain data. This program has been approved for 1.0 contact hours of continuing nursing education. And you will find that a link is available for an electronic evaluation tool. It's provided for you on the slide that's on the screen now, but you also receive this in your calendar invitation. You'll need to log in, complete the evaluation, and request your certificate. This evaluation process will remain open for 2 weeks from today's date so that you have ample time to complete the evaluation. If you have any questions whatsoever, please contact Dorothy Aldrich, and her email address is listed in the slides as well. Lastly, we encourage you to visit the OHA Sepsis website, which is a repository of resources, toolkits, and education. Now, it is my pleasure to welcome Andrea Bum of ProMedica Defiance Hospital. As patient care supervisor of the emergency department and express care, Andrea has firsthand experience with timely patient transfers, specifically of sepsis patients. Andrea, welcome, and I'll turn it over to you at this point.
Okay, thank you, James. So as James said, my name is Andrea Bum, and I have been with ProMedica for 20 years here at Defiance, and I've been asked to talk about sepsis care in a critical access hospital. Next slide, please. So specifically, I've been asked to talk about care and transfer of a sepsis patient at a critical access hospital, along with the decision-making on identifying a patient with sepsis, and maybe some barriers we may run into when transferring patients out, either within our system or outside our system. Next slide. So just to give you a little overview of our hospital, we are a critical access hospital located in Northwest Ohio. We are part of the ProMedica Health System. We are also a Level 3 trauma center. And within our critical access hospital, we do have a 9-bed ER, 10-bed behavioral health unit, a 10-bed women's center, 10-bed med-surg unit, 9-bed ICU, 5-bed OR, and a 4-bed express care that actually works out of the back side of the ER as a separate department. Being a critical access hospital, if you're not familiar with that, that means, though, we can only have 25 inpatients on a day-to-day basis. Next slide. So kind of just to give you a little idea of sepsis data for us, the average yearly census in our ER is around 19,000 patients. We see about 13,000 in the ER and then an additional 6,000 in our express care. of all of those patients, last year we treated a total of 7 patients diagnosed with sepsis. 7 were admitted and 10 of them transferred. So as you can see, as the population of this group is very small here at our hospital. Next slide. So with that being said, we do have to find a way to determine early on a sepsis patient. So within our EMR, we use Epic, and we have a sepsis screening tool built right in there. It is done during our triage process in the ER, and it is done on every patient 18 years old or older. This screener identifies those patients at a potential risk for sepsis. The physician then gets a notification through Epic, but also a verbal notification that this patient did screen high and is at a potential risk for sepsis. And the screening tool itself consists of 5 separate components. It really is a quick screen within the EMR, but I have separated it out into 5 categories just so that you can see it a little bit better. Next screen. So all of the ProMedica facilities utilize this same sepsis tool. So screening for the sepsis patient is done the same at Toledo Hospital, in the metro area, as well as any of the outlying areas. So the first thing we do have to determine in our screening tool is, were they recently treated for an infection within the last 30 days? Or are they currently here for a possible infection? The next criteria is, are there abnormal vital signs indicating potential sepsis? And that would be vital signs outside the norm that you'll see on the next screen. And if we have 2 identifiers of 2 abnormal vitals plus a recent or a current and possible infection, then that triggers a possible screen for sepsis. Otherwise, we can then determine it's negative if they do not have abnormal vitals or any recent infection. Next slide. So the second part of the tool is the abnormal vitals. Is their temperature greater than 38.3 or less than 36? Is their heart rate greater than 90? Respiratory rate greater than 20? Systolic pressure less than 90? Or mean arterial pressure less than 7? So triggering 2 of those, we would then be at a higher risk. As you can see too, it also lists white blood cell count less than 4,000 or greater than 12,000. Typically, that's not something we're going to see in the triage part of emergency care. However, it could be that patient that's transferred over from outpatient lab or from the offices that already know that they have an elevated white count, so we could use that tool at that time. Otherwise, that's one step that we aren't typically seeing during the triage process. Next slide. And then the next one is a diagnosis of infection. So this is the list of things that we are looking for if they have had within the last 30 days or if they currently are here because of this possible infection. This is when the nurse would decide that, yes, they're here for this, mark that box, and continue on with the assessment tool. Next slide. And then it comes down to analyzing the criteria that we have. So if we have that infection plus the 2 abnormal vital signs, then yes, we have a positive screen, and then we are notifying the physician. Next screen. Physician notification is documented, discussed with the physician, and then the possible ordering of the test for sepsis. Next slide. So also within our EMR, it is built in there to kind of help guide the physician a sepsis treatment plan. So the physician can choose to open the sepsis treatment plan and go step by step exactly what they need to do, especially because the small population of patients that we see here, It is a good refresher of what I need to do in the first 3 hours, what needs to be done in the next 3 hours, and so on. As you can see, in the first 3 hours, we have it listed, the importance of the lactate level, blood cultures, and administering antibiotics. Also gives them the rate of what kind of fluids they should be using for hypotension, and if the possible vasopressors within the next 3 hours are necessary, along with repeating the lactic acid. So as you can see, it will walk them step by step through this process if they choose to use it. Next slide. So then also, they can choose a sepsis order set. So this has been put together from a team within the system of the importance of what test results are important to do if you're suspecting sepsis. So this is our order set for sepsis. The one thing I'd like to mention on this is that a procalcitonin level here at a critical access hospital is not a test that we are using here to identify treatment for sepsis, as this is a send-out test for us. At a small hospital, there are some lab tests that have to be sent to Toledo by courier to get results back. So this is a time problem for us. So to be able to do this every 6 hours and get a turnaround time and a result back before the next one is due and we can base treatment off that isn't possible for this. So this is something we would leave for the receiving end to add on procalcitonin levels. Next slide. And then also within the EMR, there is a medication order set as well that the physician can go to. This is a way for them to determine of their suspected cause of sepsis and which antibiotic to choose. This isn't our entire list, but I screenshotted a portion of the medication list for the physicians. Choosing off of this certainly is a better choice than trying to guesstimate which antibiotic. So if they are ordering off this list, it's a nice guide for them to be able to determine which antibiotic is best choice. Next slide. So then we come to the decision for disposition of the sepsis patient. An important element of a patient in a critical access hospital is to determine who needs tertiary care and who can actually stay here at our hospital. There are some criteria that we consider regarding patient disposition. Some of them are hemodynamic stability of the patient, a potential need for infectious disease specialist, as we do not have one here at the hospital. Patients' comorbidities. The more comorbidities they have, the more chances they're probably going to have to go to a tertiary care. A potential need for invasive monitoring, and also ventilator support. As we do keep some ventilated patients here, long-term ventilation isn't something we would typically keep here at our hospital. We do not have pulmonology who can round on these patients and care for their ventilator support. So those are patients that we would see transferred to a tertiary. Potential need for specialties or procedures that are not available at the critical access hospital is also something that we have to consider here. Next slide. So if our disposition is set to admit here at our hospital, of course, we have to have the physician-to-physician contact from the ER to the hospitalist, and the hospitalist is the one who is going to cover the service on this patient. Handoff of a receiving unit is a verbal report nurse to nurse. So they are also looking at the EPIC, because if anyone has used EPIC, you know that allows for one chart throughout the hospital. So as the ER nurse is given a report to the floor nurse, they can be looking at the exact same chart and utilizing all the tools they have in front of them to make sure that we have not missed anything. They can talk about things that are due that haven't been done yet through the ER, and they are looking at the same documentation. Next slide. So, I'm sorry for just a minute here. My computer has logged me out. So okay. Patient disposition has been set for transfer. Certainly, we have the question of whether we would transfer within ProMedica or outside ProMedica. As our location sits very close to the Indiana line, and we have a lot of counties who utilize our services here, but maybe live closer to the Indiana line, may choose to pick a Fort Wayne hospital because it's closer to their facility. And some that live more east of here would choose the Toledo line. So decision-making certainly is dependent on patient and family preference, and also available resources at the accepting facility. We would not do a lateral transfer if they did not have the available resources there. Of course, we would have physician-to-physician acceptance. Also, handoff remains the same for the receiving facility. The nurse here would still call and give a verbal report to the nurse at the receiving end. And if they are within the system, then they're going to already be on the Epic EMR, and they're able to get that same exact real-time what's going on with the patient. Otherwise, we would include a printed off chart to send to the receiving facility if it is with outside ProMedica. We also have a second handoff, and that's also a verbal report between the nurse and the transport providers. So that report remains the same for us here. Next slide. So then it brings us to some barriers to sepsis care at a critical access hospital. One might be keeping the nursing staff competent on sepsis care. We review all sepsis cases that come through the ER, whether they are admitted here or transferred here. Next slide. We find it important to review filters at unit meetings, and this is our ongoing case management review that we do with our staff. This is done on every sepsis patient that we see here. We review all the charts. We check to see if their sepsis screen was complete. Did it coincide with the diagnosis of the patient? Did we do the screening complete? Was it done correctly? Documentation of temperature, vital signs hourly, if not hypotensive, monitoring vital signs every 15 to 30 minutes if hypotensive. Was the lactate drawn on time, and was a repeat done in the correct time frame, along with blood cultures? Also, were antibiotics administered within 3 hours of arrival? Were the IV fluids given appropriately? And were vasopressors given if needed? We find that with the small population, but this high critical complicated patient, needs some extra attention from our staff and education too. So we do review all these filters with the staff. Sometimes we might have a case review done that maybe we've really drilled down on a chart that of the things that we've done well, things we could improve on, how the patient did, the outcomes, and that really does seem to make a difference with the staff. It does help us to show how important the screen is to do on every patient that comes through here to get early identification of sepsis. Next screen. Some other barriers that we do have here at a small hospital, and being the sending hospital, is one, getting the physicians on board and actually choosing the sepsis order set. Some may just manually choose to put in their orders, and some will use the order set. Sometimes not using the order set, they may forget to reorder the lactate along with the blood cultures. If they use the order set, it will automatically repeat a lactate in the designated amount of time, and it will also trigger a reminder to the nurses of a countdown time of when that lactate is due. Also, not selecting the correct antibiotics off the list. for a suspected infection. If they're not utilizing the order set, they could certainly order the wrong antibiotic for the suspected infection. And then we review the sepsis cases also through our clinical quality team to ensure that we are giving evidence-based care to all these patients. Another barrier we have is bed availability at a tertiary center. I'm sure many of you are familiar with this about this time of year, as census has increased in many of the larger facilities. It may be more difficult for us to find beds. Although this doesn't seem to be a common problem for us to find a bed, but it does pose a challenge for us this time of year. Transport availability could also be a barrier for us too. Currently, we have one ProMedica ALS transport that's stationed in Defiance every day. However, that crew can be called to nearby towns for transport. They could be called to the metro area. They may be called to do a trip to take a patient as far as to Cleveland and back. So they are not just designated for our hospital. So in those cases, when we're in need of a transport, they could already be out in a different area for that transport. And there's only one other private ALS transport in our area, so that would be another resource for us if they are available. The other thing with transport is the need for a mobile ICU. Some of these patients who may be vented and on pressors are requiring a nurse to be on board in the transport of these patients. And that is something that would delay the time that transport squad could get here. We would have to wait for one to come from the metro area, which could take up to an additional hour and a half time for them to get here. If we're unable to find transport in a timely manner, then we would utilize a flight team, which is also stationed outside of Defiance in more of a metro area, and the ETA of that would be 20 to 30 minutes. Night shift in itself renders problems too, because there are less squads on duty during the night shift hours, which also increase wait times for us during the night shift. So between tertiary bed availability and transport delays, those are our biggest concerns with the sepsis patient, which then leads to the problem of boarding patients. Boarding the sepsis patient is difficult for us. Fortunately, this does not happen often, but it is something that we run into from time to time. Current staffing in our ER includes one ER board certified physician, 2 ER nurses from 7 a.m. to 11 a.m., 3 nurses total from 11 a.m. to 11 p.m., and then we drop back down to 2 nurses from 11 p.m. to 7 a.m. We do not have a separate triage nurse. The nurses on duty are also in charge of triaging patients that come in to the ER. So to add a boarded critical patient is difficult here, especially if ER is full. We depend on help from an ICU nurse if possible, or attempt to call staff in. We do not have on-call staff, so we cannot rely on an on-call system. There's also sometimes that maybe our ICU is closed because there are no patients there, which means there's no additional staff in the inpatient unit. So that poses a problem of not extra staff to pull to help. There's also the problem with the boarded patient is ensuring that the ER physician continues to deliver the needed care for the sepsis patient until they're transferred. As they get busy with other patients, more emergencies come in, making sure that we're on top of all the time-sensitive treatment that a sepsis patient requires. So that kind of wraps up a summary of what it's like to send and take care of a sepsis patient. From a sending facility, a small critical access hospital, to a tertiary facility, and some of the barriers that we come across with them. All I have, James, anyone has any questions.
Well, thank you, Andrea. We certainly appreciate the very unique perspective that you shared with us from the sending hospital's perspective. And I will, again, encourage everyone on the line to continue to submit questions through the chat box or the question and answer box. We do have several questions that have been submitted, and I'd like to start in with those, but please continue to send them in. So Andrea, you really gave us a very good look at the sending perspective, but specifically the sending perspective from a critical access hospital, and some of the considerations that you brought to our attention, many of us don't have firsthand knowledge of because we just are in a different environment with different resources than the ones that you had mentioned. So there was one question that asked for clarification. The attendee said on one of your criteria slides, you had, quote, resident of ECF, unquote. Can you explain why this is on the infection criteria when they may not actually have an infection?
I guess I would have to pull up that slide here.
And I think they're referring to the slide that you had initially when you were talking about the selection criteria, and whether they had recent procedure, and then the infection, I think you had various infections on there like empyema and so forth. But there was, I believe, reference to resident of an extended care facility as one of the check boxes. So we'll continue to go backward, and I believe it was one, that one that we're on right now.
Yeah, I found it in my slides here.
Yeah.
So I think that when they put this tool together, they tried to think of everything that possibly could be a cause of that. I'm thinking that I don't think that's a box we really check very often. Some facilities, because there's 11 different hospitals within our system, a lot of them have their own little say in this too. So sometimes what is important for one facility and maybe they use still shows up on the tool for everyone. So one of the facilities might have felt that they see a lot of patients from residents of extended care facilities that maybe have had something going on there recently. Maybe they had a big MRSA outbreak. Maybe they've had some CAUTIs or some other infections going on. I think that maybe we could utilize that box as we know something's going on at that facility. They came from there. Maybe that could put them at risk because they've been recent exposure.
I see. Thank you. I appreciate that. I think that answers the question. There's another question that asks about waiting times, and the question is, what is the average waiting time from when you request transport to when transport actually arrives? And I thought I understood you to mention a time frame there for ground versus air transport. I think you mentioned the air care transport, but the writer didn't specify if they meant ground, ALS, or air.
Mm-hmm. This one would vary for us too, because if we have an ALS unit here in town and they're available, they could take the patient in 20 minutes. However, if it's a critical patient and we have to wait for a mobile unit to come, that's going to be at least an hour and a half for the mobile unit to come with the nurse here to pick up the patient. So it all depends on the availability of the squads at the time. I would say probably on average, we may wait for transport before an hour or two is probably a good average length of time of waiting for a transport to take the patient.
Okay, and that's really interesting to hear because, again, it's such a difference in communities that have more options for transportation. Without turnaround time might be much less. And of course, we're working against time here. This is all very, very critical information. Next question that came in is, do you use any sort of checkoff material and or guide that is specific to sepsis care for your handoff communication? And the caller says, we are finding that nurses and providers are providing a handoff report. However, they are missing the key pieces specific to sepsis care prior to transfer to another hospital or floor. So the question again is, do you use any sort of checkoff material and or guide that is specific to sepsis care for your handoff communication?
We do not have a tool of checkoff here for reports. The nurses within the system are told to use our SBAR format, and they can march through the whole list together because they both can see the same screen, but we do not have a separate checklist for the sepsis patient for handoff.
Okay. Another question that came in is, do you ever receive feedback after transferring? And if so, how does it happen?
For the sepsis patient, we may sometimes get feedback on that patient. Sometimes it might be a physician has contacted back to the facility and asked for an update. We don't always get a feedback on those patients. It's more at a request that we get it. There's no automatic feedback on them. Unlike our trauma patients, for example, because we are a trauma center and we do send a lot of ours to Toledo, which is a level 1 trauma center, and us being a level 3, we do get automatic feedback on those. We don't have the same thing set up for sepsis here. It's more of a, if we call for an update and they're able to give us something back.
Okay. The next question is, how do you handle patient and family or clinician disagreements about transferring a patient? And I think you mentioned preference in one of the slides with regard to proximity. I think you mentioned your proximity to another state and another city in that state. But I think the question here is patient and family disagreement about moving to begin with, or clinician disagreement over the need to move to begin with. How do you handle that?
So certainly we like to have family and patient involvement at all times for any patient that's going to be transferred or admitted here. It's always kind of a good discussion to have with them, the reasons why they cannot be admitted here. I don't find too often that we have problems when we explain to them why we cannot keep them there and that we need to transfer them somewhere. They seem to understand that, especially when you can explain the higher level of care or maybe the specialties that we don't have here in the hospitals. Like we don't have the pulmonologist, we don't have infectious disease, they need to see a cardiologist. These kind of things are, you know, a rationale to the family and the patients of why the need is to transfer. And then trying to determine where they want to go. Of course, you know, it's always easier to transfer within your own walls to your system, but it is ultimately up to the patient and the family. The ER doctor always asks them, do you have a preference of where you want to go? Maybe they already established with a physician somewhere else, and they know they want to go there because they've had a physician there before, their specialist is already there. Then we're going to set up whatever means we can to get them there. Now, of course, you know, this time of year we've had problems with, we can't send you there because the hospital's full, they're not accepting admissions at this time. So then maybe we might have to have some alternative routes for them, but we would also suggest or ask them, do you have a secondary choice? And then let them have the final say on that. We seem to be able to explain and, you know, make the patient and the family happy with the decisions made.
Okay, thank you. A couple more questions. The next one is, do you have any metric or target as to how long you board a patient? And I know to this question you had, at the end of the talk, you gave us some pretty good insight into the whole boarding situation with bed availability and so forth, and some of the barriers that you are experiencing. But I think this caller is asking if you have any type of a target or metric for the length of boarding that you use.
No, we do not have a target or metric. Like I said, it does not happen too often with these sepsis patients. I feel like the critical patients we're able to get into a facility and we don't have to board them as often. It might be some of the lower acuity patients that we do find boarding more here, or behavioral health patients, but we don't have a target or metric for them.
Okay. Another question is, do you conduct mock transfers to exercise your process?
No, we don't.
Okay. I'm just curious, and to kind of add on to that question, if you have done any type of specific education with staff on sepsis transfers specifically, or even transfers in general. It sounds like, I think the numbers you gave at the beginning were out of your, I think you said 17 patients, were there 10 that you transferred, and I think 7 were admitted. So do you ever do specific education on the transfer process?
Well, we do always include in our unit meetings a time-sensitive diagnosis critique and a filter check too. So we would always take sepsis one quarter, we would take chest pain another quarter, and we would take stroke another quarter. You know, where could we have shaved time? Did we auto-launch the helicopter? We have the ability to, for not sepsis patients, of course, but, you know, for maybe our trauma patients or our STEMIs, where we can auto-launch a helicopter and get them en route here, maybe even prior to the patient getting here or minutes afterwards, without having to give them much information. We may not have a bed number, we may not have accepting, but they're coming, so that we can cut down minutes off of that part of it.
So that might be an alert from the field, from EMS. Would that be an example that you're referring to? That
would be as well as the squads in our areas are able to transmit EKGs to us from the field. So maybe we could look at that and see that it's definitely a STEMI from the field. So we're going to call the helicopter to head this way so that we can try to shave minutes on to get that patient to the cath lab, because that's our ultimate goal is, you know, how can we take time off? So patients like that, we typically, if we can get a good idea ahead of time, we might be able to get that done in less time. We do transfer a lot of patients here, so we are accustomed to the transfer process, how to get a hold of one, what's the best route to go. So we are very in tune to transfer patients.
Thank you. You mentioned the time-critical diagnoses being kind of examined on a quarterly basis. You kind of rotate them. Do you use specific criteria for that time-critical diagnosis analysis, or is it like a case review template, or what do you use to do that?
Sometimes it's both. Like in the PowerPoint, I had our sepsis case management tool up. That's very similar to what we do with chest pain. We have chest pain filters that we follow too for all of our STEMIs, unstable anginas, non-STEMIs. We review 30 chest pain cases a month, and then we have filter checks on all of those too, whether it be aspirin, did they get it, did they get their EKG done in a certain time frame, and then same thing with stroke. Did we, we look at all of those cases. Did we give thrombolytics when it was supposed to, and if not, did we document why? Did they get CT results back in less than 30 minutes, and did they get to CT within 10 minutes? Those are kinds of things that we're rotating. Then sometimes we might add in a case review on one of those time-sensitive diagnoses so that we can give more education to the staff on this is what went well, this is what we can improve on those types of cases.
Thank you so much. Andrea, that concludes the questions that we've had submitted. I want to thank you so much for giving us quite a unique perspective into the sending hospitals issues, the strengths, the challenges, the lessons that you've learned. Thank you for sharing all of that with us today. I want to thank everyone that joined us on the call today as well, and ask that you please do plan to join us again on Wednesday, February 19th for our next webcast that will begin at 11:30, at which time we hope to focus upon critical care transport perspective. So we heard today from the sender, we're hoping to hear from the transporter, and then in March, hear from the receiver. So we thank you for all of you for joining today, and certainly for all that you do to decrease sepsis mortality each and every day. This concludes today's talk. Have a good day.